Hello and good morning to all. So first of all, I would like to thank you for the introduction, and I would like to say thanks to Ahin and Alvin Marcelo and his team for this invitation to present here our experiences and share a little bit what we do in our projects and how we can and I hope it can be helpful for you, this information. Today's seminar is really the second part of a previous seminar we had a month ago, which was focused on open source health information systems. But this, I've called it part 2, and it will be more focused for small and medium enterprises. So let's say the point of view I'm trying to give you is I work for a national center in Norway. The center is also embedded in one big university hospital in northern Norway, and we directly assess the Ministry of Health when it comes to procurement and the adoption of health informatics technologies in general. So I've tried to put a focus in what we expect from small and medium enterprises. So in the seminar, these kind of businesses can understand how better they can compete and approach the public health organizations. So I will jump my introduction since you already kindly introduced me. So basically, I'm trying to answer this question. So what are the advantages from our point of view as public health organizations in adopting free open source software? And sometimes many public health bodies are not fully aware of the advantages of it. So it might be the role of the small medium enterprise to evangelize and explain them that there are really huge advantages, and especially in the medium long term, if we think strategically when it comes to data management and governance. So I have structured today's presentation as follows. So we'll start with speaking about the importance of health data and why we should treat it as a strategic public asset. For those that already attended the previous webinar, this part is mostly the same. Then I will jump into the problem of vendor locking and explaining why data is for life, but software is not. So data is something we need to keep, and we need to ensure we have we maintain data over time to have this view of the patient's life and the patient's journey in his life. And software may change within that particular time, so we need to ensure that we are able to keep governance and control over this data. And then I will introduce the concept of digital ecosystems. This is being more and more acknowledged by public health organizations, and then what small medium enterprises and businesses can do and can provide when using free open source software systems. And then I will finish on how to approach public health organizations and some real examples and one particular success story from a small medium enterprise. So I'm going to start explaining the concerns. So what are the government and public health organizations' concerns? So mostly is, I would say, it's of course liability, but nowadays it's also from a health informatics point of view, to be able to treat data as a strategic public asset. And we see that we've seen this like 3-4 years ago, that a lot of news and a great hype when it comes to the use of data, and especially the use of data in artificial intelligence to generate new knowledge and new evidence. And we saw this in these big magazines. Now, some years later, many of these magazines and so on, they have realized that the reality is much more complex. So data is not the new oil, but perhaps high quality data is the new oil. But we need to treat it as a strategic asset. We need to ensure its quality, and we need to ensure its proper governance, and have a clear strategy towards its control, governance, management, and so on, to be sure that we can use this data at any time to generate new evidence and perform research over it, to monitor drugs performance, to discover new treatments, and so on and so forth. And so with this regards, for example, we find initiatives in Europe like the European data science space, which is now in discussion and trying to establish a network for enabling data access in different countries, and the Digital Europe program. And here I'm So I have explained this challenge of treating data as a strategic public asset, and now I'm explaining the challenge on where we don't want to be. I'm using the same example as in the previous webinar because I think it's very illustrative. So from a public health organization, this is where we don't want to be, and this is where small and medium enterprises that work with free open source software have something to provide and can be very useful. I will tell you the story. So the story is like this. This is something that happened in a hospital in southeastern Spain, in a city called Torrevieja. And basically, the health trust had given some hospitals for private management. So hospitals belong to the public health trust, but the management was privatized for some years. Eventually, there was a change in the government. And with that change, the new government decided that they were not supporting this model anymore. So they wanted full public management of hospitals. So when the contract finished, they said, we're not going to renew this contract for you with this specific company, which is called Ribera Salud. That was a contractor for managing the hospital, including the health information system. And so they did. So the very day the contract finished, there wasn't a clear transition plan, and so of course the company wasn't very happy. So they ceased operations, so they stopped working. So doctors were still going to the hospital, but they didn't know if they were still employed or not. And the organization and the management was not working anymore. And also the health information system, the electronic health record, and all the health information systems in the hospital. So it was very shocking, because this is from actually the regional TV news, to see a cancer patient in the door of the hospital saying, I have cancer, and they cannot give me an appointment because they say the system is down. So they don't have any access to any of our information, and they cannot manage patients today. So it was a total chaos. And so what the health trust did was, okay, since the hospital that is now public, and we are taking it over, what we can do is let's try to access the database, and at least we can create some, maybe not use the full health information system, but use a visor to have a look at what is in there and try to start operations again. And so they did. So they connected, because they are in the same health network, to the database. And the very day they did that, they were sued and they were taken to court by Ribera Salud, which was the company. And they could not understand that. They in the TV, it was in the TV again, and they said, well, what's happened here? They are suing us for hacking this, but this is ours. And they said, well, it's not ours, because there are IP, intellectual property matters, in these databases. So you may own the system and let's say the hospital and so on, but it doesn't mean necessarily that you can access the databases, explore them, and do as you please. And that is the key. That is where we don't want to be. We don't want to be in this situation from a medical informatics point of view. They had reached a situation known as vendor locking. So they were locked by the previous vendor. They could not do a smooth transition. And furthermore, if without a clear agreement, they were not able to access the data, which legally they were the data controllers, because the hospital is the data controllers, even though the data belongs to the patient. But they could not legally access it without some litigation. So there was appointed a commission to investigate all these problems and chaos. So for small, medium enterprises, this is the situation we don't want to be in. And this is where these kind of companies, when working with free open source software, can provide a competitive advantage. Maybe sometimes they may not have let's say, the resources to develop so much usable products that can be read in such a short time as maybe a big corporate vendor. But this is a strategic thing. So this is something to think about and to explain as a competitive advantage. So this is a schema where I'm showing the situation of vendor locking. So we have the common electronic health report, and we have a database where we persist the data. Then we have a domain model that represents all our clinical information concepts, where we record in the journal, and eventually there are some systems that connect to it, some ancillary systems like the journal, PACS, laboratory information system, and so on and so forth. So, but of course, if this belongs, that is a proprietary software, I need the company to be able to access this data. We are treating health data as a strategic public asset, and our relationship, for some reason, because we are changing from provider or whatever the reason, we might run into problems if they do not give us seamless data access. So there is potentially, if I'm changing from a previous electronic health record into a new electronic health record, might be open source or not, but another provider. So of course, the vendor, the previous vendor, might not be very happy. So if, like in the case I showed you, we might tell them, well, we need you to extract the data and give it to us. So you cannot do it directly because you may have intellectual property and these kind of things that might be not allowed contractually. And we actually faced another situation, which was in integrating primary healthcare and secondary healthcare in one of our projects, where this was a proprietary system. So we had to buy the services from the company to create the first data structure and then be able to integrate with primary care. So that might not be possible, legally speaking. And then you may tell them, okay, then I need a data export like this. But if you're running a situation similar to the one I presented previously in this hospital in Torrevieja, you may have a problem because they may say, no, we're not willing to do that because there's no commercial interest from our point of view. Of course, that is an extreme situation. Usually the relationship is much better between vendors, hospitals, and so on, but it may happen as you've seen in our previous example. So it's important to understand this. Data is for life. We need to create this full patient journey in terms of data. And this has to survive softwares. So softwares are eventually decommissioned because they become obsolete and it's more expensive to maintain them than to acquire a new fully new system. But so we need to understand that data that is inside that system needs to survive that process. And somehow we need a strategy and the means to be able to treat it as we like if we are thinking about it as a strategic public asset. So there's a possibility here, of course. So we may say, well, we are transiting and we may use a health information standard like HSN Fire Opener or 13606, which is used in Spain, for example, to extract the data from the hospital system. But then again, there is a cost in doing this, in producing this standard views. So maybe not all the data can be fully standardized, and it also depends on the relationship you are keeping with the vendor and the provider. So yes, that is interesting, but it also has been warned that it's going to hamper the adoption of apps, clinical decision support systems, and artificial intelligence systems that are developed by companies that are not the one that is providing the big platform, electronic health record. So that is something to take into account. And also, contractually, some vendors do charge per transaction here. So you have some amount of transactions you can do for free yearly, but then from some point onwards, you start paying a small fee for each transaction. So if you are heavily using external system that relies on this data export or decision support, artificial intelligence, or research, clinical research, then you are running into an extra cost. And you have to be aware of that at the contractual stage, at the procurement stage. So this is something also, if we work with open source models that allow us to freely explore the system, it's something we can alleviate. So as I said, yes, there is a cost here in producing this, and not always is it possible to put all this information here in the shape of this standard, because you cannot preserve all the context in there. And also we need to know to which extent can I escalate a proprietary model, because eventually we're thinking in these ecosystems. So we need to think not anymore as a big system where and then some auxiliary systems, but more as a full ecosystem of different digital health systems in our health networks. So that said, I have presented this model, which is, I think, more from the 2000s, when mainly the electronic health reports in Europe were adopted. Um, and I've shown its limitations when it comes to vendor logging and data governance and data control. So now it's about to see other possibilities when it comes to the models for organizing platforms, introducing the concept of free open source software and so on. So basically, this is from a famous paper from Heisenberg that speaks about open platforms. And we can do this classification. I have tried to adapt it to the health informatics domain. So on the left side, we have who controls the platform technology. It can be one organization or it can be many. And on the upper side, we have how many organizations provide the platform. So it can be one organization, it can be many. So if we go for the first case, where we have one organization controlling the platform and only one organization providing the platform, then what we see is we are in a proprietary software, for example, like ethics or Sonsorian and so on. If we have one organization and many organizations, one organization controlling the platform and many organizations providing the platform, one organization controlling the platform technology in terms of governance, and one organization providing the platform as a software. Many organizations. So we will be in a licensing scheme. I haven't found any examples of this in healthcare. But I find examples of this where we have many organizations that may control the platform technologies and one organization providing the platform. Okay, so here we find a joint venture, for example, in the same region where this issue happened. There is another system that the public healthcare system uses that was developed together with 2 or 3 companies. So they own their own system called Orion Clinic, and it was a collaboration with Entity Data and I think Indra. And basically, the health trust keeps ownership of the code software, but they allow the companies to evolve it and sell it elsewhere. So, for example, they have some businesses also in Latin America where they, using the same basis of the software, they sell it. But still, the health trust that originally helped in its development and paid for it keeps ownership of it. So they wouldn't have potentially into this program. And then there is a shared model that's the most possible openly model for where it comes free open source software, where we would find that many organizations control the platform technology and many organizations provide the software itself. And here we find DHIS2, for example, Airbase, which I will explain about later, OpenEMUS, GNU, Solidario, and so on. So this is the model that allows us the most freedom, because since the code is open, I can change a provider, or if one vendor, for example, let's say it bankrupted, so I can eventually put some money on the table and say, is there any organization willing to take care of this, because the code is open source and it may take them a while to understand it, how it works and so on, but they can take it and start working with it. And it also allows us for different schemas. So not only maybe one vendor, but several vendors, one maintaining the system, other one doing the software updates, and part of it can be done also by the public health trust if they have a big IT department and so on. So again, it's important to understand that from a government perspective, data is for life, but software is not. And that's where I think a small, medium enterprise can make a difference. And now I'm introducing this concept of digital health ecosystem. So before we saw the situation of vendor locking, where we have a proprietary, a bit monolithic-like system, maybe not in terms of infrastructure, but in terms of interoperation and seamless collaboration with other health information systems. And now there is this concept where we want to head towards, and I will present also the discussion in Norway, which is the digital health ecosystem. So we don't want to see this as a one system and some, or small satellites that connect to it, but we want to see health information systems as a full ecosystem where different autonomous systems can interact seamlessly. And for this, we need a high level of semantic interoperability, where there is a diversity of vendors, because that's good also for the public healthcare systems, since they can choose those that are more competitive in terms of product prices and so on, and autonomy and low coupling in the IT world. So why is this important? So, and how this can benefit from the public healthcare organization point of view, our operations. So in first place, what we find, and this is documented in the papers you have below, we find that end clinical users hardly ever can influence large corporate vendors. So a clinician who is working in, for example, Latin America, it's hardly ever going to be able to influence a big corporate vendor sitting in the United States or Europe. So again, a small medium enterprise can make a difference there if they have local presence. Small companies cannot enter the sector due to oversaturation, and this is a concern also. We've seen these big suites that provide us with a big electronic health record with clinical decision support and so on, and they sell you their own environment. But from a strategic point of view, we want to give the opportunity to small vendors, small medium enterprises to develop new products that may create a competitive advantage, like for example, using data and using, for example, artificial intelligence. And eventually they may grow and go to other countries and sell it. And this is something we see as a key concern in, for example, in Norway also, where the economy, as you know, is focused a lot, or has been traditionally focused on fishery and oil. And we see that there's a need to allow small startups and medium companies to use the healthcare environment, highly digitalized healthcare environment, to create highly specialized products, like for example, I said, artificial intelligence or personal healthcare, and so on. And we don't want to run into a situation where we have oversaturation of one single vendor that controls all the data, and then because that we know, if a small company goes into the hospital and says, well, I would be interested in developing you, for example, a new cancer-based pathway. And when they start looking at it, they say that they need to negotiate a lot with the big vendor and so on, and there is a hassle there. And the hospital may say, well, you know, we want to do it, but this is just too complex. We don't want that situation. So we want an environment of these autonomous systems that interact in a symbiotic manner as a health ecosystem. And here I'm introducing the free and open source software in all of this. So we see that we have open source software, but it is important for us. And if you are really providing as a small medium enterprise free and open source software with the 4 freedoms we will see later, then you need to explain the difference between that and a pure open source system. Because we found, for example, in a project I will show you in Germany, that sometimes it's open source software. They are open source in image, and yes, you can go there to GitHub and get the code. But when you try to use them and you do some near live tests, you find that it's not possible actually to use it without a module or a package of configuration data that is sold by the vendor that originally created it. So now that's not really truly free and open source software, because you cannot run by yourself the software, even though you may access the code and modify it. So in order to be real free open source software, it has to comply with this. So we needed to comply with these users' essential freedoms. So the first one is the freedom to run it, the freedom to study and change it, and the freedom to redistribute copies with or without changes. That is very important. And if you're working with this kind of software, you need to make the public health organization aware of this. That it's not only open source, but it's free open source software that you are providing, and it's going to give them a great liberty. So if you don't, you can say, actually, if I don't deliver, you will have the possibility to change to another vendor, and without running into this vendor locking or other problems. However, there are common fears. These I presented them last time also. There's a lack of widely available support and maintenance. And this is a fear. And that is not always true. It depends a lot on where we are in the world and which free open source software we are using. So for example, when it comes to this support and maintenance, it depends a lot. So of course, we don't have the big suite that we can purchase and take to the and simply install it and deploy it. We may need to go into more complex contractual scenarios, but we can get maintenance. For example, if I speak with small startups, they might be interested in start learning about the open source software and providing this maintenance. And in this way, I'm also helping my local economy. So it depends a lot. Like for example, if you go into Linux systems, you will find maintenance for sure easily. In the healthcare domain, this is more complex because the relationship is more one-to-one and it's more close. But I think small and medium enterprises can easily take on open source tool or system and start learning about it and provide some teaching and also sell this support. So it's a matter of collaborating with your with the small and medium enterprises. There's also a common fear of the difficult to recruit experts. Then again, of course, it's not as easy as going to a big corporate vendor and get some consultancy from them. But you can rely also on your local businesses and allow them to learn about it. Maybe they need to train from other organizations that already have experience in this open source software. But at the end, what we find, for example, here there's a hospital which is operating a vendor product. For example, I was visiting the hospital in Denia, in Spain also, and they have Cerner Millennium. And what they say is that we had to develop our own system, our own experts on Cerner Millennium, because at the end we need the context is so different from one place to another that you need a high customization of the system. So you are always going to need to train your own personnel. In the case of free open source software, the difference is that this will have to be done perhaps with another organization, and you need to check if that organization exists to teach your local SMEs, your local small and medium enterprise. Cost estimation, I think that's a real fear. It's much more difficult to estimate the costs in a free open source software project than a vendor product, where you have a 20 pages contract where everything is established and clear and so on. Here, this is more demanding on the public health organization side. Then there is a concern on the lack of maturity. I think there's no rationale or there's no real reason for that. Nowadays, maybe 15, 20 years ago it was, but nowadays there's no real reason or basis for that concern. We just need to look at, for example, Spring, the Spring framework in Java, which is highly mature and it's used maybe in 50% of the online business everybody. And also cybersecurity threats, I think it's actually the opposite. If we think in an open source project, what we find is that it's subject to public scrutiny. So when there's a vulnerability in there, the community of users, if it has a minimum critical mass of users, will very fastly raise the concern about a specific vulnerability, for example, in a software library, and that will be fixed. Whereas in a closed product, we don't know. It depends a lot on the company, and they might decide not to fix the vulnerability right now because they need to wait and they have the resources invested in other delivering other services, for example, and they can afford to wait. Whereas in an open source project, it's not possible to afford it because that would kill the project if you have this vulnerability unfixed. Required customization, I think, disappears, as I said, in every project. Vendor or not, you're going to need to tailor the system to your particular context, because the biomedical context is so complex and it's so variable and changing from one hospital to another and from one country to another, but always customization is always going to be a requirement. And this is a real fear, I think, the lack of understanding of who controls software. It depends. Sometimes there's an non-for-profit organization that controls it. Sometimes it's not. It's just created by one big corporation that offers it as a open source software, and then you need to understand that to see if it is really a free open source software and to which extent you might be dependent on only one vendor, even though it might be open source. So here I'm not going to go into many details because I'm pretty sure many of the audience knows better than I do how to make profitable business out of free open source software. But these are just the common ways. So software subscriptions for support, tools, bug fixes, etc. And particularly in the healthcare domain, that is very important because the relationship you have with your client is not that much as when you buy a database and simply give some support for them and the IT team takes care of it. But what we see in hospitals is that the vendors work very close in a symbiotic manner with the IT personnel in the hospital and the clinicians. So just that is going to provide, I think, or has the potential to provide a good revenue for the company. There's also training and certification. Training is always going to be good for the hospital personnel. So I was, for example, it was in 2012, I participated in the foundation of one startup. And the startup is still alive, and I think that most of the revenue from the company actually came from training to health public entities. And also the new functionality development. So since the code is open and really accessible, some vendors may choose to provide more like training, others may be more focused on purely support, and others may focus on new software functionality development and create a specialized products in terms of, for example, data analytics or decision support, or taking a complex disease pathway and try to create the system to manage it, like cancer or closed loop medication and so on. And there are different ways of licensing this. There's dual or hybrid licensing also is possible, where you offer like two different versions of the software. This is, for example, done by I think Red Hat. Have two licenses, and one of them includes like more support and checked binaries. So. But I think the most important thing here is to understand this symbiotic relationship. So when it comes to software subscription for support and the training, is going to be a collaboration with fewer clients than when you work in, let's say, normal IT or enterprise IT, for more commercial environments. So when you work in healthcare, you have less, but it's a much closer relationship and long-term relationship. And they would usually, what I find is the hospitals are willing to pay for these services, because if you are providing a small improvement in their processes, this is going to save them a lot of money. So they are highly pressurized, and we don't have resources, even in a rich country like Norway. There are not enough doctors, for example, in radiology. So if you can provide a product that comes and helps them to save, I don't know, 3 minutes per patient, that is a lot of money. So, and they say they see this value, and they are willing to pay for it. So how, for us, if I'm a small medium enterprise, how do I approach a public health organization? This is not easy. I understand. As I said, I participated in one startup many years ago, and that is a key thing usually, and it's not easy to go there, since a big corporate business has a lot of resources to be there and do this, let's say, human relationship building and so on, but you don't have so many resources to use for that. So, so I think the first step would be to join medical informatics associations like AEHIN and participate actively in their events and understand what are their concerns and drive your products toward these requirements and these concerns once you understand one particular clinical subdomain. As I said, we need to build symbiotic relationships. It's not about a client-provider relationship where we purchase one particular software package and you install it in an independent manner. Especially when it is a small, medium enterprise, what we expect is to build this long-term trust in the sense that, okay, you understand my concerns and I understand your concerns. So let's reach a medium ground where you help me to be more competitive in terms of operation in the hospital. So my healthcare personnel can do what they know to do the best, which is provide healthcare for patients, and they can save time, for example, in documentation. Okay. So you have to empower them to be an active part of the digital ecosystem evolution. And a possibility here is to start by partnering a university hospital, for example, research projects. Research projects for small, medium enterprises are usually not very profitable. So, but it's good if you join and somehow you don't lose money, of course, but somehow you manage to, oh, someone is painting my screen. I cannot delete it. So you have to, I think in how, to which extent can you participate in that, because it's the first step towards building this trust and understanding their needs. And we need to see health data as a strategic public asset. So providing data for research, quality measures, etc. And also an important thing is we are running a study on the adoption of artificial intelligence, and all hospitals say the same. We want some KPIs, we want key performance indicators, but formal ones. We want evidence. We want to run biomedical informatics studies, like mostly prospective studies, where I split two groups of clinicians, one using your system and the other one not using your system, and I can actually deliver evidence that your system is actually saving time or providing some kind of benefit, and take that to the management. Because if it does, if it is worth it for us, it can save us a lot of time and therefore resources which we don't have in healthcare. And so I can go to the management and ask for more resources, and this is business for you. So I think a key point is to offer them and design with them an evaluation plan. And this is in many cases not present when it comes to the acquisition of big corporate vendors. Sometimes we see, for example, there's been some cases around in Denmark and also discussion in Norway about the lack of a clear plan for post-implementation follow-up in the sense of studying with real evidence if this is investment is worth it. And consider mixed approaches. As a small, medium enterprise, you may not have the possibility to directly go and just sell a packaged product. So you will need to participate at different levels of the healthcare organization. One project may be more about data integration, another one more perhaps about specializing with products and so on. But somehow you need some kind of flexibility to be able to provide this competitive advantage, in my opinion. So the benefits for the public health, I think, are clear when we're working with free open source software and small medium enterprises, which is, as I said, if we develop an evaluation plan, we can go to the management and start with a pilot, a paid pilot, of course, and then develop an understanding on which technology is better suited for our proposals. And then if it works, get more funding. And this allows us to minimize the risk at a high level. And this is different from what a big corporate vendor with a proprietary product may come and say, this is my business model. I sell you this package and this is it, which is another way to go. Okay, so this is going to be more complex. It's going to be in the long term, but it's going to take more time, but in the long term, it's going to be better, I think. And we also want to give, as I said, the possibility to SMPs to develop specialized products. And nowadays in Europe particularly, there's an interest in allowing them to generate artificial intelligence applications. And also we want this expertise to be built locally, because we understand that this is a strategic field, and we want our countries and our regions to have this knowledge. And this has to be developed in collaboration with local small, medium-sized enterprises. And Now I'm going to present some real examples. This is the last part of the presentation. So this is a discussion that we had in Norway. It's called Axon. Axon is a project that aims for harmonizing electronic health records in primary healthcare in Norway. Because in Norway, basically each GP office can choose which electronic health record they can purchase, even though they are public. But they have this freedom. And then interoperability is very complex. And the data use has become very complex. So what the government said is, why don't we purchase a big platform and then put all the data in there, and then we have harmonized everything, and data is there, and they use this big platform electronic health record. But then many researchers and civil society kind of responded to that, saying, well, if you do that, you may run into vendor locking, as I said before, and you don't understand the needs of your clinicians, because this big platform may be okay in another countries and may have worked there, but in a complete different context, with a complete different healthcare system. And you don't have a plan for evaluation. So we want to plan for evaluation. If you are spending several billions, we want to plan for evaluating how good this investment was, and you don't have any. So researchers, and I was actually part of it, complain that you are not doing this in an evidence-based manner. You need to work in an evidence-based manner as we do this. So a good thing in Norway is that the government usually listens to the civil society, and they are reshaping now this procurement into something that resembles more digital ecosystem. So it's still in discussion, but I think it's a proven concept. And this is the success story I told you about. This is from HIMED, which is a project in Germany. I was participating in as a semantic interoperability consultant, and at Hanover Medical School. And basically in 2015, the government allocated funds for 4 medical informatics initiatives, each funded with 30 to 40 million euro. I was part of one of them, which was HIMED. And in HIMED, we met a small, medium-sized company, which was very interested in going into the health information systems development. And we wanted to work with the OpenAir standard. And at that time, even though OpenAir is an open standard, there were no open source databases for OpenAir. So we had to purchase one, commercial one. But they said, why don't we partner and we take the prototype that there is for one of these databases that is still not ready for the real operation, but we give you some resources. So they gave us like 1 developer, and also they gave us like 2 testers, and also they gave us access to their DevOps environment, and to put some resources also from your public project. And together we make this a more mature product. And then in parallel, we will build a more commercial product on top of this open source software. And this we did. So we collaborated together, integrating a team of both people from Hanover Medical School and software developers and architects and testers from the company. And then this led to the development of this airbase from a prototype into something more mature that it's in use nowadays. So then the COVID pandemic arrived, and then the federal government said, well, this medical informatics initiatives, they are doing interesting work, and they are in a good position to actually create an environment, a national platform for research in COVID-19. And so they allocated more funding, and that's where the company started to earn money. So they had invested some time of developers and so on, but at this point they could start to earn money, and that's where they got a very nice, well-funded project to develop this platform, again in collaboration with university hospitals and so on. And also as a side story, they also started getting contracts with, for example, the Koch Institute, because they have delivered this. And I think nowadays they are selling outside Germany also as a consequence of this collaboration. So just to finish and wrap up, so the main advantages in free open source software from a government perspective is to treat data as a strategic public asset. And I think there's a clear beneficial role for small, medium-sized enterprises to provide this infrastructure in a more flexible way that allows to build this digital ecosystem. And this is it. Thank you very much. I will answer questions if you have any.
Yes, thank you very much, Dr. Luis, for that wonderful
Mhm.
presentation. And I would like to greet our participants in this call. We actually have more participants than we did last month. So we now
Mhm.
have over 70 participants in this session.
Mhm.
So to all our participants, we are enabling your microphones right now. So if you
Mhm.
want to ask you the mic, you may do so. Or if you want to type them in, you can enter them in the chat box. So,
Mhm.
Dr. Luis, we had some questions that we were not able to discuss in our last
Mhm.
meeting. So
Mhm.
maybe we can answer some of them while waiting for the others to type in their questions.
Okay.
The question is one common complaint of FOSS in my country. Oh,
Mhm.
sorry. Customers underestimate the total cost of ownership.
Yeah.
Nothing is totally free. So, how do we educate users, particularly customization, support, and integration costs?
I don't have a clear answer for that since every of this project is different. But I would say you need to pilot things. So I wouldn't go into a big investment. For example, in the 2000s, there was a big investment in the United Kingdom, which was called Collecting for Health, and it resulted in a scandal because they spent like 12 billion uh, British pounds into a project and it didn't work. So I would say that we work more gradually, and the only way to learn for the public healthcare system and public health organizations is to actually get their hands dirty and start funding some at least small projects with in collaboration with SMEs to understand all the hidden costs, and from then start gradually escalating into what I would call a digital health ecosystem that can cover a region or a country.
Thank you, Doctor. Our next question is in a combination of private and public health data, who is the custodian of the integrated data?
I can say in Europe, because these changes may change from country to country. So in Europe, we have GDPR. I mean, GDPR is very clear that you have, well, the ownership, it's actually in reality the patient, but the custodian, or what is called the data controller in Europe, is always the hospital in the cases I work in. So it's the public healthcare organization or the organization that originally captured that data during medical practice. So the company
Uh,
provides the software, but it's not the custodian or owner of the data.
Yes, thank you, Dr. Luis. We now have a question in our chat box. It's from Dr. Prasanjit. He's asking, how can we convince customers and users that FOSS is more secure? Some tends to think since it's open source, it has more secure flaws.
Yeah, I would. Yeah. So yeah, cybersecurity is there's no secure software. So we need to assume that, and we need to put the measures to minimize that risk. But if we are facing an advanced persistent threat, what is called, and this means an actor that is systematically going against our organization, we are going to be beaten, and we will need to do forensics and investigation and so on. But as I said, if you are working with a FOSS project and the community that supports it's good enough, it has a critical mass of users, the very minute a vulnerability is discovered in one of the libraries, for example, one of them will openly say it, and it should be known that there's a vulnerability there and it has to be fixed. So you can assess if that is fixed or not, because the project is subject to public scrutiny. However, in a closed system, you don't know. There are, for example, cases. You may, for example, check the case of TokTok. It's a company in the UK which was a scandal because of a big data breach. And in that particular case, it was more because they were not actually putting the measures to avoid the breach that caused that. But I think when it comes from the software perspective, if you are open source, you are subject to public scrutiny at least. Whereas if you have a closed project, you don't know. You have to ask the vendor directly, and if you don't know that that breach is present, they might also not know. So there's a higher possibility that to know that you have a vulnerability if you have one of these open projects because of as a consequence of its open nature.
Thank you, Dr. Luis. We have another question from Dr. Mark. It reads, can you possibly delve more on the phrase, it is best way to treat health data as a strategic public asset, especially relating it to data ownership, use and disposition, especially in raising funds to sustain the open source HIS?
Okay, yeah, can you repeat the beginning of the question? I didn't.
Yes, can you
Yes,
possibly
yes.
delve more on the phrase, it is best to treat health data as a strategic public asset?
I don't quite understand the question. So, so I am understand this. What can we do best to treat it as a strategic public asset? And I would say is, if you are in the government side, let's say you are facing a procurement, you need to contractually make sure that you keep in control of the data. And when I say keep in control, I'm not speaking about GDPR or custodian. I'm speaking about being able to go to the database if the moment requires so, and be able to create views from this database in a free manner if I need so, and extract data, for example, for research, health quality measures, and so on, given that, of course, that I am complying with the ethical standards I'm subject to.
Thank
So I
you,
would
Dr.
say
Louis.
be careful at a contractual stage, let's say.
All right. As Dr. Mark says, thank you. Maybe for the last question, we can answer this, Dr. Luis. Data architecture and management is complex and needs expensive experts. So
Mhm.
many countries cannot afford this. Is there any global initiative for low and medium countries?
I think, let me go there and maybe you can take I will give you the slides, but if you, I know one of these softwares, I don't remember which one, any of these, I don't know if it is Open Image. One of these is for management, actually, it was born for management. But I will investigate it and put an additional slide, okay, for this. And this is a FOSS software, so you can freely use it. So I will deliver you the slides and I will search the one that is more headed towards administration software for hospitals and so on. So I will put an extra slide with that.
All right. Thank you, Dr. Luis. I think that's our last question. So thank you for the presentation and for adequately answering our questions. Before we wrap up the session, I would like to call on Miss Christine Pascual for some announcements.
Hi everyone. To all of our participants who would like, we invite you to contribute to the developers community of the OpenMS. So OpenMS is also a free and open source software. And one of the ways that you can contribute is by first learning more about the OpenMS. So we actually have recently launched Open Image e-learning course, which is available via socialprotection.org. So this is publicly accessible and it's free, and it is also self-paced. So this course will be able to provide general introduction to Open Image and discuss also the national e-health landscape in connection with OpenMS. They use thesis in OpenMS and the role of the OpenMS community. And to learn specifically about the development side, you can also review the OpenMS Developer Sorting Toolkit, which is available through the OpenMS PC. So you can check this link on the slides, which will be shared after the webinar. And then if you're ready, we can also help you connect with the OpenMS developers committee. If you're interested, especially to present your software contribution and community meetings and upload your codes via GitHub. And then lastly, especially to our students and faculty members on this call, um, faculty members, sorry, of computer engineering departments and universities. So there were actually previous projects conducted already by the University of Mannheim and also other thesis students. So you can also actually embed OpenMS in your current curriculum by organizing development projects, activities, and research. And in line with this, we will be having a webinar discussing this specific topic on June 10, the same time at 3 p.m. Manila. So stay tuned. We will be sending the invitations once ready. So if we don't have any questions as of the moment, I think we can wrap up the webinar. Is there any Thank you.
And thank you, everyone. We'll be emailing the materials from this session. And have a great weekend. Thanks, Dr. Luis.
Thank you. Thanks for your invitation. Thank you.